and welcome. Hello, good morning, and welcome. My name is Dr. Christine Lee, and I'm the Acting Associate Commissioner for Minority Health and the Director for the Office of Minority Health and Health Equity, also known as OMHHE, at the FDA Food and Drug Administration. The FDA Office of Minority Health and Health Equity provides leadership and policy direction for the agency on issues related to the health of racial and ethnic minority and diverse populations. And we have a dedicated mission of promoting and protecting the health of diverse populations through both research and communication of science that addresses health disparities and advances health equity. Every April, the FDA Office of Minority Health and Health Equity observes National Minority Health Month to raise awareness of the importance of improving the health of racial and ethnic minority and diverse populations and reducing health disparities. We are glad to welcome those of you joining us by Zoom today, as well as in person at the White Oak campus, to our National Minority Health Month event, Strategies to Increase Clinical Trial Participation for Diverse Communities, a panel discussion with the OMHHE REACH Consortium. OMHHE established the Racial and Ethnic Minority Acceleration Consortium for Health Equity, also known as REACH, in 2023. REACH is a research consortium of diverse organizations and institutions that aim to timely and efficiently help respond to health equity needs. During our event today, members of the consortium representing organizations and researchers working in diverse communities throughout the nation will discuss their ongoing work with REACH to improve clinical trial participation among racial and ethnic minority, tribal, rural, and other communities they serve. I am pleased to welcome today our keynote speaker and co-moderator for the event, Dr. Namanje Bumpus, who currently serves as the FDA Principal Deputy Commissioner. In this role, she works closely with FDA leadership to develop, advance, and implement key public health initiatives. Chief among these priorities is the proposed reorganization unifying the Human Foods Program, creating a new model for the Office of Regulatory Affairs, and strengthening the entire agency. Dr. Bumpus was formerly FDA's chief scientist, where she oversaw and quickly elevated the research foundation, science, and innovation that provides vital support for the FDA's public health mission. This includes leading the agency's implementation of the Modernization of Cosmetic Regulations Act. Before joining the FDA, Dr. Bumpus was the E.K. Marshall and Thomas H. Marin Professor and Chair of the Department of Pharmacology and Molecular Sciences at the Johns Hopkins University School of Medicine. Dr. Bumpus' research has focused on drug metabolism, pharmacogenetics, bioanalytical chemistry, and infectious disease pharmacology. She's earned a bachelor's degree in biology at Occidental College in 2003, a doctorate of pharmacology at the University of Michigan in 2007, and completed a postdoctoral fellowship in molecular and experimental medicine at the Scripps Research Institute at La Jolla, California in 2010. Dr. Bumpus, thank you so much for being here today, and please take it away.
Thanks a lot. Thanks, everyone. Thank you, Dr. Lee, for that intro, and thank you to all of you in the room and online for joining this event. My voice is giving me trouble today, but hopefully it won't fail me during this. So I'm really honored to join you and to be able to welcome everyone joining us here at FDA and also virtually for today's panel discussion. I've been looking forward to it for a long time, ever since Dr. Lee told me about it. Thank you to all of you for being here with you. Your work is amazing, and just to sit at the table with you is really an honor, so I'm looking forward to this discussion. And as you all know, today's focus will be strategies to increase clinical trial participation from diverse communities. So I think we're, all here because we believe and know and understand that diverse representation in clinical trials is not simply a matter of biology, but also of health equity, fairness, and public trust. Fairness is an important concept that leads us to trust and justice. Equity in clinical trials is particularly important with respect to equal access and accrual to clinical trials. So there's a lot of work ongoing across our agency to increase diversity in clinical trials, and at FDA, we are committed to increasing enrollment for diverse populations in clinical trials. So today's discussion will focus on identifying tailored strategies to advance clinical trial participation for diverse communities. By embracing diversity, inclusivity, and clinical trial strategies, we not only advance efforts to support diverse communities to actively participate in clinical trial research, but also pave the way for more equitable healthcare opportunities. And I'll add that as a basic translational science, we advance science. We understand more about science. The historical lack of diversity across the range of dimensions of diversity limits our understanding just of biology. I think back to being, a laboratory researcher early on and having one of my advisors tell me, even for animal studies, we only use male animals. We don't use female animals. That's too complicated. Well, when you do that, what does that mean? Now we're leaving out so much. So I just really challenge us all to think about clinical trial diversity is important and paramount. But as we're considering this, all of it also applies to the things that we do preclinically and early on, and thinking about how do we establish that foundation as we build our biobanks, as we do our analysis, as we bring AI into our work. How do we ensure that there's diversity in that process so that we're not doubling down on any bias? But this is something that really is important across the range of things. I also will say, let's think about the workforce too, the scientific and biomedical workforce. That's really important, just even in the scientific questions that we ask and that we address. So this panel, I think, has wider ranging implications even in clinical trial diversity itself. It goes all the way to the basic science. So in addition, what really gets me excited about today's conversation is that we will hear from the REACH Consortium community leaders, clinicians, researchers serving racial, ethnic, tribal, rural, and sexual and gender minority communities. Through active engagement and meaningful dialogue, we hold optimism that our collective efforts will yield well-informed, equitable, and sustainable solutions. The REACH Consortium was established with a commitment to core values of trust, respect, and relationship building, and is an important bridge between the FDA, researchers, and diverse communities. The consortium aims to create an environment conducive to meeting the needs of diverse populations. A unique feature of REACH is that each of the 6 partner organizations consists of a core research group and a network that extends into the communities they serve. The REACH organizations have been able to amplify and elevate the voices of the populations that they serve by leveraging their community networks. So whether it is in North Carolina working with federal qualified health centers, or in Bismarck, North Dakota, working with American Indian people on 5 reservations, the HBCUs of Coppin State University in Baltimore and Xavier University in New Orleans, community centers in West Palm Beach, or the medical center in Puerto Rico, the community connection of REACH is not only vast, but also vital. And because of core concepts on which the REACH Consortium was built, in just 10 months, the consortium has been able to help provide information to the agency's centers and offices to help answer critical health equity questions and address health equity needs. From creating innovative, tailored strategies to advance clinical trial diversity for the American Indian or Alaska Native, Black or African American, Asian, Native Hawaiian or other Pacific Islander, Hispanic or Latino, and rural communities, to amplify voices for patients and caregivers in Puerto Rico living with substance use disorder, to advance strategic communication strategies, to advance food safety for diverse communities, just to name a few. So there were commas in there. That's all a list of major accomplishments and the impact of this consortium and the people that you see here. As I look at the consortium members gathered today and consider your work and your commitment to the communities we serve, I'm incredibly optimistic about what we can accomplish together to develop long-term sustainable solutions to continuously advance health equity. Your collaboration and ability to elevate your community voices is instrumental in advancing health equity in a timely, proactive, and intentional manner. As we hear from the researchers, community leaders, and clinicians joining us today, I think we'll see how much their work through the REACH initiatives embodies the National Minority Health Month theme. We must remember that we all have a role in improving the nation and leading the way to health equity for all. And with that, I want to thank each of you again for being part of this effort and joining today's discussion, and I'll pass it back to Dr. Lee.
Thank you so much, Dr. Bumpus, for such a wonderful keynote and joining us today as a co-moderator. For the next portion of our event, I will recognize our panelists from the REACH Consortium. First, Dr. Claudia Fqhc is part of our faith-based and HBCU REACH team. Next, we have Ms. Perla Nunez, who represents the Federally Qualified Health Centers, or Fqhc's REACH. We have Dr. Billy Joe Kipp from the Tribal REACH team. We have Dr. Darlene Santiago representing Puerto Rico REACH. Next is Eugenia Melender of FSU and Community Centers REACH. And certainly not least, although he almost missed his plane, we have Dr. Todd Cito from Hawaii REACH. Welcome. To help introduce our audience to the REACH Consortium, I'm going to ask each of our panelists to give our audience a brief 1 to 2 minute overview to share information about your community. Then I would like you to take another 2 to 3 minutes to share barriers that your community experiences to clinical trials. And also, I'm sure our viewers would like to know also the strategies that you have found to be effective in increasing your community in clinical trials. After we hear from each one of our REACH members, we will move to the question and answer session with Dr. Bumpus, and I will co-moderate. To kick us off, can we please start with Dr. Claudia Fqhc?
Thank you so much, Dr. Lee, and it's a privilege to be here today. As you mentioned, I'm Dr. Claudia Fqhc, and I head the University of Maryland Patients Program REACH team. I'd like to introduce the rest of our team. Dr. Jasmine Cooper-Williams, who is our Director of Qualitative Research, Dean and Professor Kathleen Kennedy, the Dean of the School of Pharmacy at Xavier University of Louisiana in New Orleans, and Dean Joan Tillman, the Dean of the School of Health Professions, as well as the Helene Fold School of Nursing at Coppin State University in Baltimore. Thank you, team. Our REACH team focuses on a few areas. First, in urban Baltimore, we focus on African Americans. In Southern Maryland, we focus on African Americans and Latinos. In New Orleans, there's a focus on African Americans, Latinos, as well as Vietnamese. The largest misconception about our communities, we've learned from a series of town hall meetings and focus groups supported by the Office of Minority Health and Health Equity, and thank you for that support. The largest misconception is that the community is not interested in participating in clinical trials. This is a misconception. The underrepresented populations are indeed very interested in participating in clinical trials. They just don't know how to access them. They say, we've never been asked. And so many of them assume research is not for their community, which is far from the truth. This is coupled with a series of historical research abuses that are in the back of people's mind and more contemporary areas that make people afraid to talk about research. Our primary barriers to clinical trials include that level of distrust, lack of trustworthiness of the investigators, lack of information on how to even access clinical trials, and lack of community practicing clinicians' knowledge about how to refer their patients to clinical trials. And so we have a series of recommendations and strategies that have been informed by our interactions with our communities that include the following. One, the need for investigators, researchers, sponsors to have full transparency, full disclosure, being able to effectively communicate complex research and health-related information in plain language that the average citizen can understand, and that is literacy appropriate. That is imperative. Next, to foster trust in research and researchers, the investigators need to go to the community, not always ask the community come to our academic institution, but to go into the community as a gesture of sincerity and desire to build trusting relationships. We also hear from them that the general public has ethical concerns about research, tremendous concerns about ethics in research, and they don't understand what protections exist, and they do have recommendations for protections to assure that the community believes that research is ethical, and these include return of research findings and return of results. We would think that as a physician and a researcher that happens. We hear many times, I participated in a clinical trial, it ended 3 years ago, I haven't heard from them. The next thing that's of interest is what's called post-study obligations. When the study is over, what next? Do you return the results? Do you provide post-study access, or at least link people to resources where they could have continuing care? Because in the course of the clinical trial, they receive outstanding health care that is standardized. After the trial, they may not hear from people, and it's back to more inequities and disparities. The other thing we're hearing is the excitement of having the community voice elevated in the Food and Drug Administration. And this includes not understanding that there are these advisory committees, there are listening sessions that people can participate in. There's a wonderful newsletter that we give all the participants, the link for the Office of Minority Health and Health Equity that talks about advances in discovery, vaccine development, as well as the commitment to health equity. And so with that, I would say that we have opportunities to train sponsors, researchers, policymakers on how to build what I call bidirectional community authentic partnerships that are to and fro, that are much more than investigators coming, we want to study you, and then never get heard from, and don't receive the results, which is a critical transgression on the part of the community. So with that, I am happy to be here today. I can't tell you, I used to be a federal scientist, and to have a consortium that says rapid acceleration, wow, that is as a wonderful opportunity to really, truly address and mitigate health inequities. Thank you.
Thank you so much, Dr. McKay. Ms. Perla Nunez.
Good morning, everyone. Buenos días a todos. My name is Perla Nunez, and I am here representing Fqhc's REACH program. Our PI is Dr. Becca Hayes, who is from the North Carolina Community Health Center Association. And just in case people don't know what Fqhc is, I'm just going to go over that a little bit. They're the largest primary care network in the country. They're federally funded, nonprofit health centers or clinics funded that serve medically underserved areas and populations. Fqhc's provide comprehensive primary care services. Some of these are dental, mental health, substance abuse, health care for the homeless, HIV/AIDS, migrant farm workers, to name a few. Regardless of people's ability to pay, they are able to get care. So it doesn't matter what people's income or insurance status they have, and that is a beautiful thing. What is also unique about federally qualified healthcare centers is that every center's advisory board is patient-governed, which means that they have to be comprised by at least 51% of consumer or patient representation. So that means that patients have a voice at the table. And again, that's a beautiful thing. And in North Carolina, we have 43 federally qualified healthcare centers that serve over 750,000 patients, and that number is going to go up substantially due to Medicaid expansion. Of those patients that we serve in North Carolina, 35% are uninsured, 62% are minorities, and greater than 90% are low income. The communities that our program is working with are rural communities in North Carolina with the African American and Latino communities. Some of the barriers that our communities face is that we come in on parachutes and want them to participate in certain projects, but we have to come to our communities with our heart and wanting to give them the information, the awareness, what they need to know about what we're asking them to do for us. So we go there, we build those relationships, we build the trust. We must come in with not wanting something from them, but bringing that information to them. And that's how you build those relationships. And then you can go in there and start having those conversations about what are clinical trials, why is it important to, enroll in clinical trials. So we must go in with that information. And one of the things that I find with clinical trials is that sometimes, a lot of the times, the sites are very far away from where the communities are, and we expect people to take public transportation, go on an Uber, use their own car, that they might not have cars, and that's the reality of the communities we're working with. The reality is that some people don't have cars. So why not have the sites where the communities are, right? Somewhere there. They know where the site is, the people talk like them, the people look like them. It's very welcoming. So let's consider federally qualified healthcare centers, free clinics, as a site for our communities. And then awareness, bringing awareness to our communities. It doesn't happen overnight. It takes time, and it takes a lot of time, and us being there, being present, not just going in and never coming back. We have to be constant in the communities and just, being very transparent that if we don't know the answer to something, we will get it. We don't just try to, because once you lose that trust, it's going to be very hard to get it back. So let's go into our communities with an open heart, bringing the information, answering all their questions. And if there's something I keep saying is we need to ask, we need to listen, and we need to repeat and repeat as many times as we have to until the communities feel comfortable about what we're asking from them. Thank you.
Thank you so much, Ms. Nunes, for sharing. Dr. Kipp?
Thank you, Paula. That was awesome. Before I begin, I would like to introduce our research team. We are the Indigenous Innovators Collaborative, and today with me we have our CEO, Stephanie Poston. Stephanie, please stand up. And we have our researcher, Dr. Myra Parker, who is an associate professor at UW, and also has a center focused on tribal research. So we are very fortunate. I will begin now to introduce myself. Oki Niskani, Nistuni Diwaniku, Billy Joe Kipp, Amskapi Pakani. What I said to you in my language is, hello, my friends. My name is Billy Joe Kipp, and I'm Pqhcc. I'm Southern Blackfeet from the Blackfeet tribe. It's incredibly important that I introduce myself to you in our language, because that is our protocol. But I also have a secondary reason for introducing myself in my language. Is when you first heard me speak, you may have thought, what is that? Is she going to talk like that, the whole thing? You know, and not really understanding where the language is from, that it comes from the heart, it comes from our people. And so when we do research in tribal communities, oftentimes we go in with a language that they haven't heard before. We use jargon that's unfamiliar. We use terms, clinical trials. Are you going to put me in the hospital and put me on trial? We use those terms that don't translate well to our people. I am currently working with tribal colleges in several Indian reservations who have students and practitioners and teachers in those tribal colleges. And the reason we work with tribal colleges is tribal colleges are the repository for education, for science, for infusion of culture in curriculum and knowledge and integration of indigenous knowledge. And so those are critical pieces in Indian country. When you work with the tribal college, you are working with the communities, but you're working with them in a very relationship-based, educational-based institution. And it's really incredibly important to point out that the tribal colleges were formed because education was very unkind to us. And so tribal colleges were formed to increase the number of our students gaining access and our people gaining access and degrees, but also to infuse and honor our cultural language and our indigenous knowledge. So it's befitting that if we're moving in Indian country, we are working with tribal colleges. I, as a past tribal college president, have recognized the need for good research, quality research, and equitable research in tribal communities. And like my colleagues mentioned, we haven't had that type of access. And so today, we are working to understand what happened. And as we look at our methodology is community-based participatory research. And as we go and work with tribal communities and tribal colleges, which are almost always located in rural areas, we include them and build relationships. So what I tell FDA almost every meeting, we're going to build that pathway for you to infiltrate and help and work with our communities in an equitable way. And even as we developed our focus group questions, we would talk with FDA and we would talk with the tribal colleges, and they would say, nah, that question's not going to work. And so that was a collaborative, very honoring process. You can't come into our communities and not honor our culture, our language, and our indigenous ways of knowing. And tribal colleges can help guide us. They are the function of education, they are the function of relationship building, and they are the function of good, equitable research. I'm honored that we have partnered in this initiative with FDA. Our tribal colleges are honored to be in this relationship, and our tribal communities are. And I thank you, Dr. Buck, for coming today, and Dr. Lee for allowing this presentation. Thank you.
Thank you, Dr. Kipp, and thank you for being here today with us. We are very appreciative. Moving on, Dr. Santiago.
Thank you, and thank you, Dr. Kipp, for such an amazing words. I'm humbled, and I don't know how I can speak right now after your amazing words, so thank you. My name is Darlene Santiago. I am from University of Puerto Rico. I am one of the PIs of our REACH Consortium. First of all, I wanted to thank the FDA for organizing this activity and for literally having me sitting at the table where we're having such an amazing conversation and interchangeable ideas that will transform the way that recruitment is being performed to increase diversity in clinical trials. I am a clinical researcher and a translational researcher. Therefore, I'm a trusted member of my community. I go to the clinics, I recruit patients in Puerto Rico, and I can say that we're very enthusiastic to participate in clinical trials. We want to be invited and we want to be included. I hardly ever receive a no from a participant that they're not interested in participating. Again, they are taking their medications, they know the barriers, they know why medications aren't working, and they understand the areas of opportunity to better and to enhance the care that they receive. So I became a trusted member of my community largely because I am Puerto Rican and I look very much Puerto Rican and I speak Spanish and I speak with my words so they can understand it, but most importantly because I gained their trust. That was a process that happened. It did not happen overnight. I suddenly appeared on the clinics and I started recruiting, but I was very honest and I was very genuine of my intentions. And with all of the studies that I conduct, I always go back to the community and I go back to the clinic and I share the outcomes of my research, how I published it, how many poster presentations I did, and I sit down with the physicians and with local members of the Department of Health, and I just show them the data and I show them some proposals how we can change, how medications are used in Puerto Rico. So joking aside, I think that our REACH Consortium, learning from our experiences as clinical researchers, we know what's working in order to recruit patients in Puerto Rico. So we need to go to the clinics, but we need to speak in Spanish, and we need to be honest about what we're doing, and we need recruitment strategies that go to the communities and help participants decide whether they can participate or not. And we need informed consents that are in Spanish and not Spanish from other Hispanic populations, but Puerto Rican Hispanic, which is it's not the same. So we want to use or leverage existing entry points for people to have access to clinical trials in Puerto Rico. There are clinical trials being conducted in Puerto Rico. There could be more. We can have that conversation another day. But they're mostly focused in the San Juan metropolitan area. Even though we're a small island in the Caribbean, San Juan, it's not only Puerto Rico. There's Ponce, there's Orocovis, we have the coast, we have the mountains. We have people spread out the entire island. So it's important that we, for example, train future pharmacists from Puerto Rico. I'm from the School of Pharmacy. And we tell them these are the skills, so this is what clinical trials are. So when you graduate and you get your PharmD degree and you want to go back to that community, to that mountain in Orocovis and set up your community pharmacy, you can help recruitment of Hispanic Puerto Ricans in clinical trials. You can be an extension of the REACH Consortium in Puerto Rico, and you can be an extension of the FDA in order to increase participation of Hispanic Puerto Ricans in clinical trial. So we want to expand that network of trusted community members in Puerto Rico. Also, we're looking at adding recruitment strategies into the protocol, into the curriculum at the medical sciences campus, either pharmacy students, physicians, MD students, nurses. We want everyone as being trained to be a provider in the future, that they learn about clinical trials and the importance to recruit members of our community in order to increase diversity. And lastly, I just want to make the invitation that even though this is a lot of information that we're just throwing out there, we recognize that it's a lot of work to be inclusive and to be diverse in clinical trials, but that's why we are here, and we're open to work, and we want to collaborate, and we want to just work together to increase that. So I just want to finish with saying that allow us to help you help us. Thank you.
Thank you so much, Dr. Santiago. Dr. Melender?
Hello, everyone. Buenos dias. And I want to start by saying thank you to the FDA and to the Office of the Commissioner for allowing us to have this platform to really speak for our community. This is a unique and rare opportunity, and truly this is where you really align the words with the action, and it really matters in our community. I want to start by saying that I am Eugenia Flores Millender, and I'm from Florida State University and the Center of Population Science for Health Equity. I am a multi-race, Afro-Latina, indigenous person, community-based neuroscientist, and first-generation immigrant from Panama. And I say this because these guys, how I see the world and how I do research. For example, our team is made up of 3 MPIs who are right here in front of me, Dr. Frankie Juan and Dr. Casey Javier Ho, and 2 community partners who have equal voice in our team. We have Boris, who's representing the community campus LGBTQ+ Community Center, Joao, who's representing the Guatemalan Mayan Center. And this is important because what I say is that we as researchers, we know things, but they know just as much. They have different experiences, and those experiences will make our experiences better in research. And together as a team, we see multiple populations within our project. We look at sexual gender minority populations that are often ignored in research. We are also looking at Asian populations that are often overlooked in research, Hispanic and Black populations that are underrepresented in clinical trials as well. Some of the misconceptions about our population and community is that we are not all the same. We are all different. Sexual gender minorities are not all gay men. They are interested in HIV research. We have bisexual individuals, non-binary, transgender, lesbians, who want to know about diabetes, who want to know about cardiovascular disease, who want to know about different equipment and how to be healthy in general. We also have Asian populations who are not all Chinese. We have different regions. We have the East region that represents the Chinese. We have the Southeast or Filipinos, South Asian, Indian, and Pakistanians. We are all Hispanic populations, as you see in front of you. We are now all European Spanish, right? We are Afro-Latinos. And within that, we also have indigenous groups that are from Central America and other places. They have their own indigenous language who do not speak Spanish, are always included in different populations. We also have the Black populations you have Afro-Caribbeans, Africans, African-Americans. So these groups are not homogeneous. So do not study us as such. We are different. We have our own culture. We have our own language, our own health beliefs. We are not one solution fits all. So for that reason, some of the barriers that we face is that we're not included in clinical trial until the end. When you have the COVID vaccine and you're looking for help at the very last minute, include us from the very beginning. Include us in your conversations how and why things are important, so we could tell you how to do it better. We also want to make sure that you include us in leadership positions. So, for example, we have NPIs who are doing research with us. They are here. They're speaking with us. Boris, Joao, they're going to kick us out of FDA. So, well, let's go. Ask the questions and we'll get kicked out together. Because this is what it is. I want them to hear directly from the FDA. I don't want them to hear through me, from me, because it is them who really makes the difference. We want to make sure that they have sustainable support. So when you have grants, make them in a leadership position so they could become PIs in those grants to sustain the infrastructure, to allow the researchers to help them build that trust, to build that sustainability. And obviously we want to make sure that they have an equal voice and equal opportunity from throughout the beginning and the end of the process. Thank you so much for the opportunity to allow us to share that with you.
Thank you so much, Millender, for sharing. I know I learn a lot through all of our conversations. Dr. Cito?
Aloha. I'm Todd Cito. I'm a cardiologist and clinical researcher from Hawaii. I'm here with my co-PI and partner in crime, Dr. Deb Tyra, who's here with me. We work at the Queens Health System, which is the state's largest healthcare provider. We have an aspirational goal as a healthcare system to reduce the disparities in Native Hawaiian mortality compared to general population by 50% in 10 years. So it's very ambitious, and for me, it's very rewarding to understand how the FDA and the Office of Minority Health Equity are part of that journey with us. So I appreciate being here and understanding the partnership that we have and friends who can help us with that. We work with Native Hawaiians, who are the indigenous people of Hawaii. We also work with Pacific Islanders, who are the people with origins in the South Pacific, so Micronesia, Melanesia, Polynesia. And that's a general population that we work both with clinically and with research. The misunderstood, I think, perception of Hawaii, Hawaii is a wonderful place to live. I'm very lucky, great quality of life for many of us. We have the longest life expectancy in the U.S. I think it's almost 81 years, almost 3 years more than the average in the U.S. Despite that, there are really kind of real, significant and persistent disparities in Hawaii. Native Hawaiians in particular have the lowest life expectancy, tremendous disproportionate burden of heart disease, lung disease, stroke, diabetes, kidney, and so on, kidney disease. And those burdens really are at the root of those disparities. And the work that Dr. Tyra and myself and our colleagues throughout the state are trying to do is understand beneath that what's driving those disparities. The barriers to clinical trials in Hawaii, I think, is partly geography. We're an island state. Population a little bit less than 2 million, maybe 1.5 or so, I believe. Most on one island, Oahu. But we're 6 islands. 90% or so of the state, of the land, is rural. We're separated by water, obviously. Need to fly between the islands to receive care and other things, being clinical trials. So the real geographic barriers. And the diversity is a strength for Hawaii. We're the most diverse, racially diverse state in the U.S., majority minority. With that, though, comes the fact that we're not a monolithic society. So Native Hawaiians, Pacific Islanders are not monolithic. In particular, Native Hawaiians have their own history of historical harm, overthrow of the Hawaiian Kingdom, mid-1800s, annexation, some would say illegal annexation, and the burdens that come with that and disparities that drive that. From our research, interviewing patients with diabetes, we found 2 main things. First is that there's a gap in awareness of clinical trials. Native Hawaiians and Pacific Islanders often haven't heard of clinical trials, don't know what it is, kind of misunderstand what the term means even, and haven't been offered opportunity to be part of clinical trials. And that's a striking difference from the white patients that we talk to separately, a marked difference. The second point is that they're very interested in being part of clinical trials. We know that they want to join. Majority actually are very interested, so they're there. Particularly if we work with their trusted primary care providers, and that's the key. Working through the diversity, working through their primary care providers, doctors, nurses, and others, to engage them in enrollment trials. So for us moving forward, our goal is to think about how to apply community-based research methods that we heard about to industry-sponsored trials. How do you do that? How do you combine those parts? So we have 4 main thoughts. One is to engage those primary care providers, educate them, teach them, engage them in what research is. The second is to mentor, train research staff, research nurses, administrative staff, clinical staff about what research is. The third thing is to probably centralize and share resources. We have to kind of be more organized in how we do clinical research, share resources, share education, share training, share people. And the last thing is to probably set up a data system that allows us to collect information on who our patients are, how they're being enrolled, and so on. So I'll say, one thing I could say real quickly is that I'm struck by how similar our experiences are across everything I heard. I wanted to make sure I echo and kind of amplify things that I heard, because what I heard really resonates with what our experience is. I focus a little bit on what our Hawaii experience is. I want to be clear, a lot of shared words, thoughts, barriers, hope, goals that I have with you. So for me, it's a pleasure to be part of this panel, and it's an honor to be here. And I'm just super appreciative of Dr. Lee, Office of Minority Health Equity, to let us talk and have you listen to us. So thank you.
Thank you so much, Dr. Cito. I have to say that I think the pleasure is all mine, being able to meet everyone in person and not just through Zoom. I know we have very limited time, but I do want the audience to know if you do need additional information on the work that the REACH Consortium has done, please visit our OMHHE Enhanced Equity Research Hub, where you can search for the overview and information on their projects. I think that is already abundantly clear how REACH is helping us connect to the diverse communities throughout the entire nation. So thank you for that. We will now move to the Q&A part of the event, where Dr. Bumpus and I will co-moderate. And Dr. Bumpus, I believe you have the first question.
Sure. So the concept of trust came up some in, your remarks. So I'd like to say, we know that trust is a critical core concept in advancing clinical trials, and we've heard a lot about the importance of trust, and we often overlook talking about how to build trust, even though it did come up some. We can expound upon that, and the importance of then maintaining that trust once you build it. So I wanted to start with Dr. McKay, and wonder if you can tell us about how you are working to build and maintain trust with your communities.
Thank you very much for that question. Our philosophy, our values, and our commitment are to bidirectional community researcher partnerships. And you mentioned a word that is imperative. It's to sustain and maintain. It's not a start the partnership and then never go back. And we meet the community where they live. We don't have them come to the university. We listen to them, and someone just mentioned that provides feelings of hope and develops trust. Now, I will say that typically we view trustworthiness of the investigators, of the sponsors, as a precursor to development of trust. And so in order to expand trusting partnerships, we feel there has to be a deliberate education and training of sponsors, of policymakers, of researchers in how to build those bidirectional partnerships. At the same time, there has to be education and awareness in the general public to increase their not only health literacy, but their research literacy and steps to how to access clinical trials. And finally, we believe in dual training and education, where the researcher and the community are in the same room being trained, so that each understands the values and the concerns of the other. Thank you.
Thank you so much. Dr. Millender, we have spoken about trust, but more importantly, the specificities of building trust. And I think you've mentioned that it's not as difficult as we think it might be to build trust. Can you elaborate?
Yes. It is not difficult when you're doing what you love to do, which is community-based research. But what is difficult is the conceptions that sometimes because you look like the community, you know what the community needs. And then we're coming as researchers with that on the table. We actually need to hear what the community says and work with the communities hand in hand to make sure that the voice of the community is always there, not what Eugenia wants as a researcher, but what Boris wants as a community member from Campus, or what Joao wants from the Guatemala Maya Center. Together is how we make the impact. We will have to make sure we also understand that community-based research takes time, and you have to be there for the long haul. You can't just be there, here, and there when you want something. You have to be truly committed to the community, ongoing, not only when you want research, but also what they want from you sometimes. It could be where, Eugenia, what do you need? Do you have expertise in this specific thing that we need some support? Sure. It is not something that I need for research, but it's something they need. I need to be available for that all the time. We also have to make sure and respect that they themselves have their own research agenda, right? And you just have to guide them and provide the support. So sometimes to be a good research leader, you have to be a good follower as well. So we make sure we do that. We have to make sure we create the pipeline. So here, having my community partners is like, oh, this is exciting. Maybe we want to be more involved in this kind of type of community-based clinical research. What does that look like? And it's just exciting to see how the light bulb is going on, and Boris is just taking on and asking questions and wanting to know about this. So to me, that brings joy as a researcher, because I myself cannot bring that message and that energy to the community. They're here, so it's powerful. So just developing that education hand on hand is very important. So I echo what we're talking about. Let's not just be us as a researcher in the room. Let's bring our community partners in there to have an equal voice throughout the whole process.
Thank you. Right, so we'll go next to you, Ms. Nunes. So can you please tell us how REACH has helped you build and maintain trust within your community, specifically in rural communities?
Thank you for that question, Dr. Bumpus. And I just want to say thank you to the FDA and the Office of Minority Health and Health Equity for creating this consortium. It means the world to us who are advocating for those that don't have a seat at the table and don't know how to ask the questions. We can be that voice for them. And I've just enjoyed the last couple of days meeting my fellow consortium groups. We have a love and a desire to bring our communities information about what clinical trials are. So that has been one of the most rewarding things for us. And for us, we've been conducting focus groups with community members in the rural communities. I've done some in Spanish because I'm bilingual, so great opportunity for me to use my Spanish. And also with community health workers and providers. And, the common theme from all of them is trust. Trust is key. Like, don't come into my community asking me for something until I know who you are and I know what your intentions are. They want to participate. They want to hear from us. But they want to hear it also in person. And they want to be able to ask questions. Don't just give me a flyer. Don't just give me a pamphlet. Give me that information so that I can take it home and read it afterwards, but talk to me about it in person so that I can ask those questions. And, what I've done in the past, I've given people my phone number because I'm like, I know you're going to have tons of questions when you get home. So just call me, and that's just me, Perla, who likes to do that. I don't mind, talking to people about it. So, that's what this REACH Consortium has done for us. And so I thank you for allowing us to have this opportunity. Thank you.
All right, thanks for that. So, to Dr. Santiago, it would be great to hear from you how you think that REACH is helping strengthen trust between your community and FDA.
That's a great question, because we were previously talking that in Puerto Rico we have FDA presence, and we have also a large presence of pharmaceutical industry. So Puerto Ricans know about the FDA. They know in a higher level what FDA does. So when we talk about our REACH consortium in Puerto Rico, and we talk that it's FDA funded, we're like, oh yeah, I know FDA. It's easier to explain that than to say we're funded by NIH or other institutions, because we know FDA, it's something very familiar to us. So people understand where we're coming from, and I think speaking with honesty regarding of why we're doing what we're doing and what is the end goal, I think it's really important, and that they understand, because I feel that knowledge is power, and we're dealing with members of minority groups that we're all knowledgeable. We all have Facebook. We all have Instagram. We all have Google. So people know stuff. And for us to share with them the purpose of what we're doing, what is the end goal, why we're here, and just being honest about the benefits but also the risk factors, I think that is very crucial to sustain a long-term relationship, just like a marriage. So for us, we feel that the REACH Consortium, it's bilateral in the sense that we are an extension of FDA, but also an extension of Puerto Rico, because we understand that flow of information. I think I answered your question. Thank you.
Thanks a lot.
Dr. Kipp, it has been a pleasure to be able to work with you and your team. Can you tell us about how REACH has been able to strengthen trust between the tribal nations and the FDA?
Thank you, Christine, for that question. It's really difficult in tribal communities to develop trust because all our institutions that we have governmental policy and governmental connections with are indoctrinated in non-trusting practices. And so we've had to redesign our educational institution. We've had to redesign our healthcare institution to meet the needs of tribal nations from a helping place and not a harmful place. And so trust is a huge issue in Indian country. But in our work, we have worked intensely with tribal colleges and tribal nations, and the trust is developing. So we've done one round of research focus groups, and we're going back this next week. And this next week's integration with the tribe is we're having a focus group with tribal elders and a traditional meal. To me, that's trust. To me, that exhibits trust. And so I think it's critically important that we understand that the development of trust isn't like, okay, at the end, we trust you. The development of trust occurs when you incorporate our community health workers in your plan, when you incorporate our personal care assistants in your plan, when you incorporate our students at tribal colleges who are probably providing care for auntie or grandma in your plan. And so that's what we do. We incorporate those access points, those organically knowing, helping folks in our communities in the plan and give them knowledge, give them supervision, give them hope. The whole thing is not changing just around clinical trials. It's changing organizations to meet the needs of tribal people and allowing tribal people to be equitable partners. And that's what REACH is doing today, is allowing our tribal people to be equitable partners. We see you, we hear you, we're going to do something different. Thank you.
Thank you so much, Dr. Kipp. Dr. Cito, you've talked a lot about how clinical trials is a way to increase trust of regulated products for the Native Hawaiian and Pacific Islander communities. Can you explain to us what this means?
Thank you for the question. Again, I'm a cardiologist, so I don't read as much as I'd like to, but when I do, I read the main clinical journals, New England Journal, Cardiologist, Circulation, JACC, and so on. And when I look at the studies of the major trials coming out and look at the Table 1, right, that has demographics, I don't see Native Hawaiians and Pacific Islanders there. So when I sit next to a patient and talk about a new drug, a new device, whatever it may be, it's hard for me to say, yeah, it's going to work for you. Or vice versa. They're going to ask, how do you know it works for me? Right? And so without that representation in trials, once the drug is out, the device is out, it's hard for me to really be assured when I prescribe that. I do. I try my best, but that conversation is a little bit more distant than it could be. On the flip side of that, I've struggled with, what the goal of a clinical trial is. Part of it is contribute data, contribute knowledge to the world, to society, to our industry friends, so they can get their products approved. But there's value more than that, I'm coming to realize, and part of that's developing a culture of science. Being involved in clinical trials is the highest quality of care, right? So also just providing high-quality care, period, whatever arm you're in. I really believe in that. But also, if the primary care physician, if the patient, if their family are part of the clinical trial around that medication, that benefits us, the community, right? Just be involved in it and forget everyone else. Just for us, it helps us be familiar with it, to use it. And so the link, in a way, between using an approved product, device, medication, where it may be, is actually starts at the clinical trial side. Get us engaged at that part. Get it familiar. Build that culture. And then the next step, prescribing the medication, inserting that device, will be easier, more familiar. And the conversation for me with my patient, in the community, and with the families is much easier.
Wow, there's so much wisdom here, and it comes from experience, and I just love that. Thanks so much again. So this has really been, I think, meaningful and impactful for all of us, and the theme for National Minority Health Month, Be the Source of Better Health, I think we can reflect back on this panel is that, and I'll say by extension, better science, like really thinking about that broader, better science across the scope of it, so thanks. So maybe we can go down the line, and it would be great if we could just, each of you in, 30 seconds, tell us maybe something you haven't gotten to tell us yet, something surprising or something that stands out about your research or anything about the communities you work with that you'd like to share with us. Start here.
Yeah, so one of the things that I did want to say about our REACH program is that one of our aims is to create a curriculum for providers at federally qualified healthcare centers and community health workers, or promotores de salud, to be able to talk to the communities about what clinical research is, why representation matters, all the information about clinical trials, because I think they're a trusted source. They're in their communities, and having them be that source of information would be a great avenue for this. And the other thing that I want to say is that I invite the FDA, the Office of Minority Health and Health Equity, to come to our communities. I'd love for my communities to meet you and see that the FDA is not somebody behind this door that nobody has access to, that they are real people, that they care. So thank you.
I'd like to mention briefly first that we're very fortunate to have two premier deans, Dean of Nursing, Dr. Tillman, and Dean of Pharmacy, Dr. Kennedy, who will be producing the next generation of health equity researchers and clinical trial researchers. And as part of that education and training, they're incorporating how to build trusting relationships with underrepresented communities and how to foster willingness to participate in clinical trials. But I'll say from the wonderful town hall meetings that we have been conducting, to learn and have confirmation about the community's interest in ethical considerations about research and how exactly do researchers protect the ethics, and making concrete suggestions to us about the informed consent process. That is, they believe informed consent discussions should include guarantees for return of research findings or results, and then a discussion about what post-study care or access will be provided. And so that has been very rewarding to have specific, concrete recommendations about the research process from our communities, as well as confirm their tremendous interest in ethical protections and ethics in research. In fact, many of our groups, after our discussions, would like to receive copies of the Belmont report and more discussions about the actual principles of Belmont, which originated after the closure of the PHS untreated syphilis study in Tuskegee. So thank you.
Thank you, Dr. Butkus, for this opportunity. I think it's really helpful to to understand that when I first started this journey with clinical trials, we were starting our focus groups in one of the tribal colleges, and there I sat with my sisters who were fellow tribal college presidents before, and one sister who I just love and I see her as a mentor kind of went to me and she said, Billy, what you talking about clinical trials? That don't even exist. And so in our way, that kind of talk, that kind of backhanded thing is a way to tell you, you know what, you're okay, but is this really serious? So clinical trials is that foreign to us. This is our scholarship, right? And so, but as we got into the communities and talked to tribal leaders and talked to tribal students, it became quick that there was not an awareness of what clinical trials was. And so what the tribal leaders, tribal college presidents, tribal college students say is we need curriculum. We need more information. They don't want us to do it. They want capacity on their own right to do their own research. And how can we help that? Well, we do what we're doing now, relationship-based research. Relationship-based research, and everybody is equitable. So that time of the expert and the subject, that doesn't work in any country. But the researcher and a collective, meaningful, relation-based research does work. And so I thank you, Dr. Butkus. I thank you, Dr. Lee, for allowing me to elevate, me to speak for tribal nations, and to honor our ancestors who have never had an opportunity to speak in these spaces. Thank you.
Again, this is so unfair. But I echo the magnificent voices of the women that spoke before me. I think that the take-home message is that we are here. We're not going anywhere. Our groups are growing. Health disparities exist, so we need to address them. So thank you for having us. Please do include us in further events. Please help us amplify the voices of our communities. And to the people that are connected in Zoom, involve us. Just reach out to us, reach out to the FDA. We want to be included. We want to participate in clinical trials. We want to be invited. And we have a voice, and we are speaking about it. So thank you.
Yes, I agree with everyone. Definitely want to make sure that our community have a voice, but more importantly, want to make sure that you're not coming to us just to check a box. We're not there for that. We want to make sure that our community's voice are heard. So they want to make clinical trials sexy again. But what does that mean? That means that you have to include us in the process. You have to hear what we think is important, not what you think is important, or how to implement culture-appropriate clinical trial research. Because it is not all about a black and white paper. Maybe that paper needs some spice into it, right? Maybe where it's pictorials, visuals, videos, where our music, where our food, and that is what really appeals to us. Don't come into our home and say, I just fill this questionnaire, have coffee, have tea, have food, get to know what's first, and then that's how we start engaging our communities and start to make clinical trials sexy again. So thank you so much for giving us this opportunity to not only talk to the community about what it is about, being part of clinical trials, but also this wonderful group of individuals. Okay, I think definitely together we're much better, and hopefully we already starting to brainstorm about different projects we could do collectively throughout the nation to really show the impact of this consortium that we have created. Thank you so much for the opportunity.
Thank you for the opportunity. I'm just trying to think how to make that a theme, that making clinical trials sexy again. The next grant, I'm kind of thinking, how do you make that an acronym? I don't know how to do that, actually. I think I wanted to echo again and kind of amplify everything I heard. It's relevant for our work in Hawaii. Again, I'll say it, and it echoes again what I heard before. There's a gap between the hunger, interest, support for clinical trials amongst Native Hawaiian and Pacific Islanders, and then the reality of what the involvement is in clinical trials. There's a huge gap. And what is surprising and scary, intimidating in some ways is that it's up to us then to fix that gap, right? The communities, they're ready to go. And it's up to us to close that gap. And again, I'm grateful that FDA is going to help be partners in that. There's so much work to do, and it's just a pleasure to be part of the team in the REACH Consortium.
Thank you so much. I know we're a little over time. With that, I would like to wrap up our panel discussion. Thank you so much for being here and sharing. Sincerely, thank you. I know I always learn a tremendous amount. Also, thank you so much to Dr. Bumpus for your inspirational remarks and co-moderating this very important panel with us. What we have heard from today is that trust is not only a critical element, but there are very actionable steps that we can take to not only build trust, but the importance of maintaining trust within your community. We also heard that while there were some nuances, there were many, many similarities across the discussion today in advancing clinical trial diversity, including supporting and expanding capacity and infrastructure for training, curriculum development for tribal colleges, Hawaiian medical schools, HBCU pharmacy schools, HBCU nursing schools, fairly qualified healthcare providers and community health workers, just to name a few, to really train and develop the members of the community to increase their skills to be part of the conversation and education. Thank you to each one of our panelists. Thank you for being here for this informative discussion on the work that we do. And on behalf of Dr. Bumpus and our colleagues at FDA, we look forward to continuing working together to advance diversity in clinical trials and together reducing health disparities. Thank you for those that have attended on Zoom and in person. Thank you for coming in. I know traffic is not that easy. Before we close, I want to encourage everyone to visit the Office of Minority Health and Health Equity website at www.fda.gov/health equity for more information on National Minority Health Month. And while you're there, please check out our library of resources, including information on clinical trial diversity, and follow us on our newsletter, which I think Dr. Claudia Baquet mentioned. So please sign up for our newsletter and follow us on X, formerly known as Twitter, at FDA Health Equity. We wish you all a happy, safe, and healthy National Minority Health Month. Thank you.